Now on to identification of pericardial effusions. So terminology, any space that does not return an echogenic signal is called anechoic. Okay, and that just means that there's nothing else to really reflect echoes there. And ultrasound travels extremely well through fluid, okay, especially when there's no densities, like whether it's blood or pus, to reflect any signal. It goes right through, okay, and that's why we don't see a returning signal, and that's called anechoic, because there is no echo. And this really helps distinguish fluid-filled cavities from other tissue planes. This is why when you look for a pleural effusion, for example, you can see the lung extremely well, because it actually helps you to characterize the tissue that's between the probe and the regularly aerated tissue. You'll see a variety of terms from echo-free to echolucent. Okay, and so if you look up on the literature or in a textbook, or someone refers to this space, they may use a variety of terms, but the conventional term would be anechoic. Pleural effusions are often a source of diagnostic confusion, okay? And by often, I would like to, that's like capital O, underlined, highlighted, because they are often a source of diagnostic confusion. And realistically, when we look at pericardial and pleural effusions, there's really a high prevalence of both of these pathologies in ICU patients. And so when you start looking for pericardial effusions, you're probably going to find them, and you're going to find a lot of them. Okay, but the reality is they are often not contributory to the patient's clinical status. They can be, but it's to focus on not letting them distract you from what the clinical problem is at hand. And so, just to abbreviate it, pericardial effusion and pleural effusion, PEF and PLEF, they're both equally important because both can be concerning. And this should always be your first question. So here's my first rule of determination for presence of pericardial effusion. I will not confuse a pleural effusion for pericardial effusion. I will not confuse a pleural effusion, and so on and so on. So this is our kind of first thing we're going to talk about here, is really separating these things, because this is often the most difficult part to really separate out on patients who are ill. So we're comparing, these are two parasternal lung axis windows. They're obviously two different patients, but they both have very distinct features which can help us delineate whether one's pleural and whether one's pericardial. But rather than me talking, maybe if someone wants to speak about what kind of features we can use here to separate what's pleural and what's pericardial.
You look at the descending aorta.
Okay.
It's often helpful.
Excellent.
The wraps anterior to the aorta would be more suggestive of pericardial effusion versus a pleural, which typically does not respect, which won't respect the descending aorta.
Yeah. So that effusion and a pleural effusion will really kind of wrap around that aorta, right? Mm-hmm. And that's because there's actually there's a pericardial reflection right next to the atrium, and that's where it traps the fluid. So on screen left here, you can see that there is this anechoic space which goes anterior to the descending thoracic aorta. Okay, and so that's a very important feature of separating pleural versus pericardial. So this is pericardial here, and you can see there's a large echogenic component that's beneath that effusion, because that's actually often in inflated lung, or could be an effusion itself actually. And you may see, if someone has pericardial and pleural, you may see separation of both, okay, and a fine echogenic line separating them. On screen right, as Adam here mentioned, you can see that there is this large anechoic space which goes posterior to the descending thoracic aorta, okay. And if you actually look closely, maybe I can convince you that there's actually another layer here, okay, and that's actually pericardial. So a tiny little pericardial effusion, which is surrounded by a larger left pleural effusion. Okay, so this is one feature, and it's an important feature, which as you guys do more and more of this, you'll recognize with time it becomes more distinct, the signal. Okay, and when you're in the heat of the moment and you're looking to see if this is an important contributor to a patient's clinical status, I would urge you guys to really take your time. If you're not certain, you can ask your colleagues, talk to cardiology, because it can be very difficult. Patients can have suboptimal windows, they can have massive pleural and pericardial, and it can be extremely hard to really differentiate what those pathologies are. So why is it so important? Well, obviously they're different pathologies for one, but also because a pleural effusion technically can cause also a similar pathology called right ventricular diastolic collapse, which we may see in tamponade. Now, this is not well reported. We've seen it in puppy dogs. This was a study actually done in 7 dogs where they injected bilateral effusions to basically cause an increased pleural and subsequent pericardial pressure, resulting in a similar phenomenon. So this is not common. However, things like a tension, hydro or tension pneumothorax can cause a similar hemodynamic compromise. So it's not to negate the effect of a pleural effusion, and it is important to realize when that can be contributing.
Is that a right or left pleural effusion?
It's a left pleural effusion. Yeah, it's left-sided. Because of course the cardiac chambers are really predominantly in the left side of the thorax. You may occasionally see an effusion to the right or anechoic space to the right of the ascending thoracic aorta, which could be a right pleural effusion, but it's not common to see that.
You get it on the right is that you get a tension right hemothorax, for instance.
Yeah.
It's not actually the fluid that'll cause the RV compression, it's the mediastinal shift.
Mm.
So the fluid won't be there, but perhaps everything else, the shift will cause compression on your right side.
Yes.
So you're right, far more rare.
Yeah, definitely not as common, but.
I had a case in CV that I may bring along next time.
Pardon me?
I had a case in CV that may be an example of this.
Tension pneumothorax in the CV ICU. Yeah, I mean that's more common where you've seen it where it's kind of very procedural, or someone's had an intervention like a thoracocentesis where you have a degree of suspicion, or you have a complete opacification of a hemithorax. That's where you're more apt to see it. Now you can look for a pleural effusion too. Okay, I know this is jumping the gun. We will have sessions in the future looking at assessment of the parenchyma and pleural space. But this is the left side. So on the left side, this is with the probe oriented with the marker oriented towards the head. Okay, and so in this case, what we're seeing is the diaphragm, which is a lunar hyperechoic structure, which below that is usually the spleen. Okay, and now we're seeing an anechoic space here, which the margins are the diaphragm, chest wall, and we can see a bit of the lung here coming into view. So this is pretty characteristic of a pleural effusion, and this can further maybe help sort out whether or not this is a significant pericardial or pleural. If you're thinking it's unlikely pericardial and you see this helps add fodder to your argument that maybe it's pleural. The next thing is you really see it in many views. Okay, so pericardial effusions are oftentimes, if they're circumferential and they're surrounding the heart, they're seen in many views. Okay, so yes, there can be incidences of local pericardial tamponade, but they're far less common. And for the sake of this talk, we're not really going to be touching on that. Our focus is really more commonly on their circumferential and symmetrically distributed effusions. So you can see here in the top left, if you look beneath, you can see beneath the posterior wall here, there's an anechoic collection. Also anteriorly as well, there's also an anechoic space. Now if we turn the probe 90 degrees and get our short axis, we can see the anechoic space surrounding the left ventricle here, and that helps, again, further add to our thoughts that this is likely pericardial. So that just, again, you should see many views. That's really with any ultrasound-based artifact, is you can mitigate artifacts by looking at it for other views. Here's a subcostal view of a patient who's, as you may be able to tell, quite sick and has a large anechoic space surrounding the heart. And when you have this large anechoic space, it does usually help to delineate the structures very well because of a property called acoustic enhancement, where the ultrasound waves can actually amplify signals when there's fluid separating probe and tissue. So this is a subcostal view. We'll talk about the physiology here in a bit. The next thing is when we look at the IVC, for example. So this is the IVC coming inwards. Okay, this would be the hepatic vein. It's kind of coming in out of view there, but this is into the right atrium. Okay, and what we're seeing here is again separation of the actual right atrium from the pericardial space. And so when you look at the IVC, you may see this anomaly. And so this is at the atrial caval junction, where you'll see fluid initially. So I think one of the most important things to realize is that pericardial separation is a very common phenomenon. And so, calling everything an effusion may be wrong because it may be just separation. There are lots of reasons like fat that can lead to the appearance of effusion. And it is often a bystander, and just to not let distract you from the main clinical problem. we will go through how we sort out an effusion really becomes a hemodynamic problem shortly. But just to keep this in mind that you will often see a lot of them, and they may have very little impact on the patient's clinic.